that leaves me to introduce our next speaker, who is joining us from New York. So we first of all have to thank her for waking up nice and early. Lexi Mellis, I hope I've pronounced that properly. You can start sharing your camera exactly, and hopefully we will hear you as well. Welcome to Social Bridges, and thank you so much for taking part. We are very excited to hear what you have to tell us today on the health behavior and mental health during COVID-19, looking specifically at a New York-focused cohort. So we get to shift across the Atlantic now for more of this global perspective on the COVID pandemic. Over to you. Thank you so much, Lexi.
Good morning, everyone, or good afternoon. Can you see my slides?
Yep, that's right up there. Great.
Great, wonderful. All right, hi, I'm Lexi, and thank you so much for the introduction. It's been really interesting to see all of these talks this morning, or what I could catch. And I'm going to be presenting on the impact of COVID-19 on mental health and decision-making, representing our group based out of the New York University School of Medicine in Manhattan. First, some disclosures. Paul Glimcher, who is the principal investigator of this study, is a principal and founder of DataCubed Health, which is a health tech company that provided pro bono the mobile application that we're using for this study. They didn't have any say about the slides, but you should know that he owns the company. And he's also the recipient of funding from the National Institutes of Health. Dr. Candace Raio, another collaborator and the co-manager of this study, is a recipient of a NARSAD Young Investigator Award, and I have no disclosures. So I wanted to give you all some context to how we thought about this over here in New York State. And it really gives a timeline of the project. So COVID was first reported in New York State in early March of 2020, and the state officially went into lockdown on March 22nd. And within 3 weeks, we launched our COVID story in a convenient sample, recruiting primarily from NYC. So this was really when cases were peaking in New York. The framework that's motivated much of this research has been identifying that, of course, as we all know, COVID is stressful. And we know that stress affects many domains of people's life, but especially physical health, mental health, and decision-making. And in particular, the COVID pandemic, especially as it was apexing here in New York, felt like this unprecedented, unpredictable, and completely uncontrollable feature, which we all know is part of what makes a canonical stressor. So as we were developing this study, Candace Raio, who, like I said, is co-managing the project, developed a COVID stress assessment. And given the longstanding literature on what makes something stressful, she led the charge to specifically measure not only global or general stress rates, but specifically the perceived controllability, predictability, and coping of the pandemic and response. Because, like I said, we know these are central components of what makes something stressful. We also focused on how proximal the threat to COVID was to individuals. So is this something you're concerned about that's impacted you personally? Has it impacted your household? Has it impacted your community more generally? And finally, it's certainly possible that people will experience different levels of stress across different domains of their life. For example, someone may be very worried about catching COVID themselves, about impact to their physical health, but not at all worried about, for example, losing their job, or vice versa. And so we're tracking the impact across all of these life domains as well. And then downstream, like I said, we're interested in looking at how stress propagates through people's whole lives. So obviously COVID is an infectious disease pandemic that can itself impact physical health, but stress has also been shown to put people at risk for various diseases and to exacerbate existing physical health conditions. Obviously, stress is directly connected to mental health, both exacerbating pre-existing conditions and putting people at greater risk for transitioning to clinical states. And it's also deeply connected to decision-making, which is a previous area of interest for the lab. And this is really where Dr. Glimcher's work has broadly investigated decision-making, more recently looking at stress effects with Candace. We've looked at a whole bunch of decision-making measures, but today I'm just going to talk about two. And these are two that we measure specifically with behavioral economic tasks. And the two tasks that I'd like to discuss are temporal discounting and risk and ambiguity preferences. Both of those we measure by looking at decision-making about money. So for example, in a trial of a temporal discounting task, we might ask someone, would you prefer $5 now or $10 a month from now? Canonically, this is presented with just options on a screen, where we can then, across multiple trials, vary the value and the delays of these rewards to determine how these two parameters change people's preferences. Similarly, in the risk and ambiguity tasks, we would ask people, would you prefer $5 for sure or a lottery ticket with a 75% chance of $10 and a 25% chance of winning nothing, of winning $0? We canonically might represent that with this square, which we call an urn, that depicts the probabilities of this lottery ticket that people can choose to either accept or reject. And then in a subset of trials, we'll actually obscure some of these probabilities. So this is representing uncertainty. We call these ambiguous trials, where the exact probabilities are not known or are not presented to individuals. And again, we can vary, in this case, all three of these parameters to understand how they impact the subjective value of the rewards on offer in a given trial, and then how they impact people's decision-making more generally. So there's been a fair amount of previous work connecting these behavioral economic decision-making measures to people's health, especially statically. So there's been quite a bit of cross-sectional work connecting static decision-making status at a single time point between individuals and connecting this to health behavior, as well as psychiatric conditions and in some cases physical health. So one widely replicated finding is that individuals with substance use disorder tend to prefer more impulsive choices in a temporal discounting task, which this has also been seen to some extent in overweight and obesity and in medication adherence, again, with greater impulsivity being associated with these higher burdens of health conditions. But more recently, there's been some work tracking the dynamics of these decision-making features and connecting those to specific health-relevant behaviors. So these are longitudinal assessments within individuals. And as one example, just from our own lab, a recent project by Canova, Lopez Guzman, and others followed individuals in treatment for opioid use disorder and found that immediately prior to relapse to heroin use, approximately 1 week before, ambiguity tolerance increases. So the probability of choosing these lotteries where the exact odds aren't clear to someone increases prior to heroin use. So this is tracking a time-specific increase in risk factor using decision-making tasks, which is really like I said, what we connected to our framework as we developed this study. So our overall goal is to track the effects of COVID-19 on subjective stress responses, on physical health, on mental health, and on decision-making dynamically throughout the pandemic. So for us, rather than using emailed surveys via RedCap or cross-sectional Qualtrics link, we are using a gamified mobile application that participants download onto their own smartphones. Every day, people receive a notification saying, "Good morning, it's 9 a.m. Please complete your assessments." These are 5 to 10 minutes per day of a rotating assessment battery that includes self-report surveys and also gamified tasks. The gamification is important here in part because we're not compensating people, but the app is beautiful and fun to use, which is, I think, a help to us. So as soon as people sign up, they get to customize their avatar. They receive, they get the chance to set their hair and their skin color, but they also can purchase outfits, or in this case, like a little unicorn with gems that they earn by completing surveys. Every day, people will see which surveys are available to them here, and they can progress along this world, revealing illustrations and kind of revealing just something kind of nice and pretty to look at by completing their daily tasks. And like I said, some of these tasks are self-report surveys, but they're also gamified versions of the behavioral economic decision-making tasks that we've previously developed in the lab that are appropriate for self-administration without a researcher having to explain what this lottery ticket looks like, for example. Now we have people choosing between 2 gumball machines, one of which is guaranteed to give you $5 and one of which might give you $26 or $0. The particular measures that we've used, that we've deployed using this application are all connected to the features that we discussed in our framework. So we're assessing the impact of COVID in people's lives generally, what news they're consuming, the economic impact for that person or that household, as well as, especially here in New York, whether people are participating in any civil unrest or protests, which is a major feature of life here. We're also measuring stress longitudinally. So repeatedly, people complete the COVID stress assessment that I introduced earlier, but they're also completing some other canonical stress and psychological scales. We're assessing physical health using both COVID-specific symptom checklists, but also looking at sleep and food diaries. We're assessing mental health using previously validated clinical scales, the PHQ I know Micah was talking about earlier, as well as depression and anxiety inventories that are more appropriate specifically for clinical populations. And like I said, we're measuring multiple components of decision-making, but today I'm just going to talk about delayed discounting and risk and ambiguity tolerance. So obviously this is a pretty wide battery, but we're only having people do 5 to 10 minutes of it per day. We're doing this through rolling assessments. So for example, on the first day that people consent to 0 days post-consent, they're asked to complete the COVID stress assessment and also to report any COVID symptoms they might be experiencing. Again, this takes less than 10 minutes. But then each day they'll receive a notification for a different randomly scheduled assessment. So each day it'll be something different. And for example, it's not until the second day that we actually get demographics on people. So depending on the analyses, our sample size really varies for this. But you can also see here that there are some measures that we assess every single week. COVID stress and social distancing or social distancing compliance are 2 features of this. And every day we get COVID symptoms. Recruitment is ongoing. Like I said, it began through Facebook ads on April 8th, but we are still recruiting for the study. We are still interested in getting more responses. So far, approximately 300 participants have consented. We're seeing a mean retention of about 5.5 weeks, which is pretty exciting for us. We get most of our key measures within the first 30 days, and here we get some interesting additional longitudinality there. Like many convenience samples and like some of the samples I've seen here, our group is overrepresenting females and people of white ancestry, especially compared to New York City as a whole. But now I'd like to get into some of the preliminary results that we have seen. So first, I'd like to focus on this COVID stress assessment itself. So we talked about the controllability, the coping, and the predictability, these perceived levels of stress response, which you can really think of as resilience factors. So higher controllability you would presume correlate with lower stress. And that is generally what we find. So in addition to having people complete this COVID stress assessment, we also asked a one-shot question: how stressful or threatening do you find the COVID pandemic to be at the current moment? We do find, again, focusing here on just controllability, people who report higher controllability of the COVID pandemic across these domains of their life also report lower stress. And we see the same thing with distraction. So we asked, how often do you find yourself distracted by or thinking about the pandemic, which could connect both to just how burdensome this is in people's lives, but also some kind of rumination, we've talked about previously, which could be especially relevant for clinical subgroups. And again, we're finding this generally lower resilience among people who find themselves distracted by the pandemic more often. We're also, on a preliminary basis, starting to look at the response dynamics in COVID stress and in this what we're starting to think of as resilience factors. So here I've subsampled down to just 20 people so you can see what's going on. And you can see that there are some distinct individual differences in how people are responding to the pandemic. So in general, is black line here, you can see the average trend across all participants, which has been towards slightly increased resilience since we launched the survey in April. But I'd like to highlight here 2 specific individuals who really exemplify what we're looking at overall, and what we'd like to follow up with some dynamic analyses. So down here in teal, you can see someone whose response has been kind of varied over time. ultimately leading to a decrease in their self-reported resilience in later periods of the study. You can contrast that to this person in blue who's shown, quite marked increases in resilience over time. And one of the things that we'd like to follow up and continue with this on is to see how these slopes connect to other features of health behavior, of physical stress, of physical health, and of decision making. I'd like to just briefly talk about physical health. Like I said, we do have sleep and food diaries, but here I'm just talking about COVID itself and COVID symptoms. Overall, we see that about 6% of our sample reports COVID symptoms. So far, most of these are mild and moderate symptoms, with a relatively small proportion of our sample saying that they had tested positive for COVID, but they did not have those symptoms. We expect this to change as testing availability increases, especially here in New York. But when we look specifically within this subgroup, these people who report having had COVID either themselves or in their household, we see that their self-reported resilience, the COVID stress assessment score, decreases with the severity of these COVID cases. So those who report having an extremely severe case of COVID, here in orange, or an extremely stressful case of COVID, also report lower resilience to the impact of COVID in their lives. Next, I'd like to talk just about mental health, focusing on the personal health questionnaire. So we're actually using a modified version of this, which only has 8 questions to avoid asking about self-harm or suicidality. So these aren't quite the clinical cutoffs you might be expecting if you're used to working with the PHQ. But we do still see results that are broadly very consistent with Micah, with what you were talking about earlier. So here we see that, again, the same pattern, reduced resilience among people with greater burden of these mood and anxiety disorder symptoms assessed by the PHQ. And at this point, we don't know the directionality of this response. We've had more measurements of the COVID stress assessment than we have of the PHQ. And we're interested in tracking kind of the relationship between these two variables, whether it's something where initial PHQ score predicts later reported resilience or burden of COVID as a stressor, or vice versa. We can also look at this among, like I said, our group who report having had COVID symptoms or having tested positive for COVID. And here we see comparable results with PHQ as we did with our resilience factors, where those who report a more stressful or a more severe case of COVID are also reporting greater mood and anxiety disorder symptoms. And then finally, I'd like to talk just briefly about some of our decision-making results. So here, first, I'd like to focus on delay discounting, our measure of impulsivity, where people are choosing between either a more patient option or a more impulsive option. And what we find is that those who tend to make more patient choices on this monetary choice questionnaire we're using to assess delay discounting are also, again, reporting greater resilience to COVID-specific stress. And then as people increase in their impulsivity, in their proportion of impulsive choices, we see decreased resilience. And we're not sure, again, the directionality of this relationship at this point, but it's something we're really interested in disentangling. And then finally, I'd like to end on some of our most exciting preliminary results. And I'd really like to get some feedback from how other people think about this, because we're really intrigued here. So here we're separating out, again, those people who have had COVID and those who haven't, specifically looking at people who have had COVID themselves now, separating out, not just in your household, but you yourself. And we're looking at impulsivity, again, that same direction that I was talking about before with impulsive choices on this delay discounting task. What we find is this trend where this is when we estimate it most conservatively. There's a slight increase in proportion of impulsive choices among people who have had COVID. And like I said, what we're thinking about here, especially what I'm thinking about, I have a background in substance use disorder research, and there we really talk about delayed discounting as a risk factor for the development of diseases that are associated with your health behaviors. So we're wondering, could this represent some kind of risk factor where those who are more impulsive are at greater risk of developing COVID? And we're not sure. Like I said, data collection is ongoing, and right now this is just a cross-sectional analysis. But we also see some interesting relationships and distinctions between those who have had COVID and those who haven't when we look at the risk and ambiguity task that I introduced earlier. So here, when we're looking at percent risky choices, so down here are people who chose more safe options, and here are people who chose more risky options. We see a difference where those who report having COVID are making more safe choices in both risky trials and in ambiguous trials. So across both domains of this kind of risk and uncertainty feature that we think about with decision making, we're seeing safer choices among those who have had COVID. So current directions overall, so far we've observed dynamic responses to the pandemic, changes in stress and resilience within individuals over time. We've made some initial connections between COVID stress and those resilience factors we talked about and mental health. And we've seen some preliminary associations between decision-making and COVID itself. We're continuing recruitment as the pandemic changes, especially here in the US. We know that COVID is not done with us, and we're expanding our recruitment outside of the New York City area. We've always allowed people to be outside New York and enroll, but we're really interested in looking at those other places as they experience the same kind of fluctuations in COVID cases that we did here in New York in April. And also, as I said, our analyses are ongoing. For example, we're looking at the dynamics of stress impact and those slope analyses I discussed, looking at whether changes in stress response relate to mental health and decision making, following up our decision making analyses with COVID status, and especially looking at as people transition to COVID, do their decision making factors change? And we're also looking at additional measures that I didn't discuss today. We've collected working memory, we've collected social distancing and other decision-making tasks, other psychological scales, and like I said, food diaries. So I'd like to thank everyone on our team. This has been a huge project, and we needed a lot of help to pull it together. But also, like I said, we are still recruiting. So if you are interested, our study is open to anyone in the US. Please promote us if you have a Twitter following. And please email myself or Candace if you have any follow-up questions. Okay, thank you.
Thank you so much, Lexi. That was very impressive, and I can imagine just how much work went into the project and will continue to go into the project. And we'll be certain to share your link with everybody that we are in touch with, and I hope that everybody watching will do the same. It is only by collecting this kind of very comprehensive data, and I think that's probably the best way of describing what you presented today. Is really a comprehensive view of what changes our behavior, and that sort of leads me into one of the key questions that have come up, which is you mentioned some of your key findings are those that talk a little bit about whether or not developing COVID may result from impulsivity or some sort of predisposition to risky decision making. Obviously, it is something you're probably going to do, but surely if you've got longitudinal data, you might have people who start out as non-COVID.
Yes, and then transition. That is exact, and that's part of why we're really interested in collecting data in other places as they experience this rise. So far, like I said, only about 6% of our sample reports ever having had COVID. So out of 300 people, we don't have that many who transition from not having COVID to having it. And that's really the group that we want to target to disentangle what is a risk and what is a consequence.
Great. I mean, that sort of leads me into then other behavior, which you said you're not going to tell us about, but maybe you'll give us a sneak peek into, other sort of potentially risky behavior, which is, food consumption, which maybe has links to your previous work on alcohol or substance abuse. I mean, the way people abuse food as another very rewarding behavior. Maybe that's something you're already considering, but that was another.
Yeah, so I know I've worked specifically with like prediabetes before. And thinking about these problem foods in the same way as we do problem substances. And we do see generally similar relationships there with impulsivity as we do in the addiction space. But like I said, we have not gotten to that part of analyzing the data. We're still so excited to be collecting it.
And do you have any predictions as things go forward, and hopefully your sample outside of New York bumps up? I mean, I think most people would assume that there's a big West and East Coast divide in terms of impulsivity, perhaps. And so, just general cultural, I mean, obviously both within the United States, but such a large country, such different subcultures.
Yeah.
Any ideas of predictions as to what you'll see if you get a nice
So I won't speculate whether West Coasters or Southerners or Midwesterners are more risky, but I will say that we do collect region, and we look forward to including it as a covariate.
Excellent. Yeah, it just occurs to me that you have this incredible opportunity, depending on how widely it's spread, to make some very interesting
observations,
cross-sectional observations, as it were. Do you have any data that you think you might be able to share at some point, how the individual behavior is influenced? I mean, this may be something else that you could do cross-sectionally, by outward, regulations and enforcements and, and policy, because clearly, one thing that we can say from the New York case is that you've had very specifically guided public policy.
Yes, and I think that's really important. We look at not only whether there are policies in place, so is like social distancing currently being required in your area, but we also look at public health messaging about this. Have you seen any messages? Who were they from, and what did they generally advise? And especially because that's something that has, like we said, varied across the United States. It's something that we're looking at connecting to that social distancing behavior itself.
I will unmute myself before I start speaking. That's usually the best way to go about it. So if you do me a favor, and maybe even if you could paste that link, because I just realized now it's
not clickable. Yes.
I'm having a moment where I feel like my son, where he touches.
Yeah, you're trying to touch the screen,
and you go, no, it doesn't touch. But yeah, if you could maybe either send me that link by email or post onto the whiteboard, we can ensure that is spread far and wide. And that sort of just leaves me to say thank you so much for your time and for the incredibly good talk. It'll be so nice to hear more about your data as things proceed. I'm sure there'll be lots of people who want to follow up with you. And without further ado, I'm going to switch to our next speaker. Thanks again, once again.